Sashti Invisible, sir.
Yes, carry on.
Good morning, sir. I'll be presenting a case of a 54-year-old male, resident of Ankleshwar, Gujarat, farmer by occupation, presenting with a chief complaint of yellowish discoloration of eyes from past 2 months, with loss of weight and decreased appetite from past 2 months, and pruritus from past 1.5 months. Patient was apparently asymptomatic 2 months back when he developed yellowish discoloration of eyes associated with darkening of urine and passing clay-colored stools. Jaundice was progressive in nature and associated with itching all over the body. He also gave history of abdominal pain, which was more in the right upper quadrant and the upper central part of the abdomen, which was dull aching in nature, continuous, non-radiating, mild in intensity, associated with nausea, with no relation with food or postural changes, and with no specific aggravating or relieving factors. He also gave history of decreased appetite. Earlier, patient could take around 4 to 5 chapatis per meal, which later on reduced to around 1 to 2. He also complained of unquantified weight loss noticed by loosening of his clothes. Patient also gave history of fever with chills and rigor 20 days back, which lasted for about 3 days, which was relieved with medication prescribed by a local medical practitioner, where blood investigations and ultrasound abdomen was done. There was no history of fever, malaise, or body ache. There was no history of recurrent abdominal pain in the past. There was no history of abdominal distension, hematemesis, and melena. No history of blood transfusions, chest pain, hemoptysis, or any complaint of back pain or bone. Past history: there was no history of similar illness in the past. No history of blood transfusion, drug abuse, or any known viral illness. Patient is a known case of hypertension from past 11 years, controlled on medications. There's no other significant or medical or surgical history. Personal history: patient is chronic smoker from past 30 years, smoking around 8 to 10 BDs per day. Non-alcoholic with mixed diet, bladder habits and bowel habits normal. Patient has disturbed sleep pattern, and family history not significant. I would like to summarize my case, sir. He's a 54-year-old male patient, chronic smoker, presenting with progressive jaundice associated with dark-colored urine, with constant dull aching pain in the upper quadrant and the right upper quadrant and upper central part of the abdomen, with pruritus and loss of weight and decreased appetite, with history of fever with chills and rigor 20 days back, which was treated with oral medication.
Can you come back to your history of jaundice, please?
Yes.
Can you put the slide back?
Yes.
So you have mentioned jaundice associated with itching all over the body.
Yes, sir.
Anything other than that you would like to know in this patient of jaundice? You have mentioned in your summary, but I think itching also, okay, you have mentioned that asymptomatic developed yellowish discoloration of eyes, the darkening of urine and passing of clay-colored stools.
Yes.
So, what do you interpret from this jaundice that the history that he's in?
So, points that I would like to note is, first of all, that jaundice is progressive in nature, sir. It is associated with pruritus. Yes. Patient also gives a history of fever with chills and rigor, sir. And it is also
about jaundice. Suppose I say only about jaundice. So you have mentioned 3 things. So what is your interpretation based on this?
Sir, considering it is a progressive jaundice associated with pruritus and fever with chills and rigor, sir, it goes, according to me, more likely in the favor of malignant obstructive jaundice, sir.
So it looks like an obstructive jaundice. So how would you differentiate in the history from an obstructive jaundice from a non-obstructive jaundice based on history?
Obstructive jaundice,
sir, that is not fever.
Yes, yeah. Sir, dark-colored urine, sir, and clay-colored stool goes more likely in the favor of obstructive jaundice, sir. And
anything else? Pruritus?
Pruritus, sir, pruritus.
And second thing is, what is the feature that is, what it is showing that it is having a progressive jaundice, you told? It is gradually increasing, that's what you want to say. So, what is the difference between a progressive jaundice and an intermittent jaundice? Does that give you something important in the history that in direction to you?
Sir, intermittent jaundice is mostly seen in benign cases, like in patients with choledochal lithiasis might present with intermittent jaundice, sir. Goes more likely in the favor of benign causes, sir. While progressive goes more likely in the favor of malignant etiology, sir.
So, usually a malignant etiology or anything which has caused a complete obstruction will lead to a progressive jaundice. Even an impacted stone will cause a similar thing. And suppose I say, why is it not a viral that is causing jaundice?
So viral hepatitis usually present with prodromal symptoms, which is then followed by an icteric phase, sir. Prodromal symptoms
so he has fever. He has fever. Sir. He has jaundice.
Yes, sir. Sir, usually prodromal symptoms, patient present with low-grade fever, sir. with malaise and associated features like malaise, joint pain, nausea, vomiting. And that is then later on followed by an icteric phase, sir, in patients with viral hepatitis, most commonly seen, sir. While in this case, the patient presents with progressive jaundice with itching and fever
And
is
he had
also
high
high
grade
grade.
fever.
I guess a high grade fever with chills and rigor, sir. So that is why I
So
interpreted it
now,
as.
does your fever give you anything clue about where we are moving towards?
Yes, sir. It probably a malignant obstructive jaundice leading to cholangitis, sir. That sort of fever.
So what is the most common
May
cause
I
of
interrupt, sir?
cholangitis? Yes,
Yes,
sir.
sir.
Please,
Yes, sir.
please.
Yeah. What about periampullary carcinoma? Intermittent jaundice is not there in that.
Yes, sir. Vaccine and waning pattern is seen, sir.
Yeah, you should remember that. It's a malignant obstructive jaundice, but still
Yes.
it is intermittent.
Yes.
So what sir is wanting to say is that an ampullary carcinoma is different from a head-of-pancreas mass or a cholangiocarcinoma.
Yes, sir.
Ampullary carcinoma can have intermittent bouts
Vaccine.
of jaundice, which gets spontaneously relieved also.
Yes, sir.
Now my question is, what is the most common cause of cholangitis
Sir,
in
choledocholithiasis, sir.
any population?
Choledocholithiasis is the most common cause of cholangitis.
So you have to understand there's a difference between a patient with jaundice having a fever, cholangitis, in a tertiary care center. The most common cause is still not, it is not choledocholithiasis. In a tertiary care center, it is post some intervention procedure, which is usually for malignancy. For a normal routine center, yes, the cholangitis can be present because of CBD stones or because of other causes as well. But in tertiary care center, most of the patients are referred to you, so they comes with a diagnosis of periampullary malignancy for which you get a stenting done, and that is the more common cause of jaundice. Why should stent cause jaundice?
Sir, stent, so basically it induces infection in a sterile bile, sir. Any external intervention would cause an sterile bile to get infected, sir, by through an external source, sir. So that is why. And although there's bile stasis, sir, so
What are the other causes despite putting stent? If you find after a few days the jaundice starts progressing again, what are all the possibilities for the stent?
sorry, sir, I didn't get your questions. Apart from stent, what are the common causes, sir?
No, you have put a stent.
Yes, sir.
Jaundice is coming down,
Yes, sir.
but after a few days it starts going up again.
So stent blockage could be a cause, sir. The stent might have got blocked, sir.
Which is more common, stent migration or stent blockage?
Migration, sir. It
Yeah,
depends on
so
the
it
type of
depends on
stent
that.
that was. On the
Remember,
type.
stent is not a sine qua non for relief of jaundice. There are many disadvantages of stent. Could you enumerate some of them?
Sir, stent migrations or stent blockage in patients with plastic stents, sir, there are more chances of stent migration. And stent blockage, sir, and repeated cholangitis are most commonly seen in patients who plastic stents were put. As compared to metallic stents, sir, the stent migration rate is less, sir, but in non-covered metallic stents, stent blockage rate would be high, sir.
Yeah. If you do a biliary intervention, should you put a stent mandatorily after ERCP?
So it depends if the patient has jaundice, if the patient has
The patient has
sir,
obstructive jaundice.
yes, sir.
For that, you are put for that you have put a stent. It will lead to cholangitis. But
Yes, sir.
imagine a patient with obstructive jaundice. What are the indications for stent?
Sir, indications for stent
Is
would.
biliary intervention in the form of ERCP biopsy, is that because you introduce contrast into the sterile system, you can
Yes,
cause a cholangitis. So that's
yes.
why many gastroenterologists, after doing an EPT for periampullary carcinoma, they put a stent immediately. Because if the biliary system is drained, the incidence of cholangitis falls.
Yes.
So, in continuation of what Dr. Ajay was asking, can it be viral hepatitis? You have to remember that there is a phase of intrahepatic cholestasis in viral hepatitis also, when the patient can have dark urine, clay-colored stool, and pruritus. But the history of viral hepatitis is, as you rightly said, that first there is a prodrome of low-grade fever, malaise, weakness, anorexia, tiredness, which is then followed by jaundice. And those who smoke, they complain of a typical history of aversion to smoking during the prodrome. They don't want to or they don't like to smoke. And it is unlikely that jaundice of viral hepatitis will go on for 2 months in a progressive manner. And that is what Dr. Ajay was saying, that you have to differentiate between progressive, intermittent, and as Sudeep has asked, what is the difference between intermittent and waxing and waning jaundice? Intermittent jaundice is that jaundice comes and goes in episodes, and that is, as you rightly said, characteristically seen with CBD stone. Next common cause would be choledochal cyst. Next would be biliary stricture. So basically benign obstruction. Benign incomplete obstruction is more likely to cause cholangitis. Malignant complete obstruction is less likely to cause cholangitis. And this is the frequent dilemma which students face in the exam. But it is well known that even with malignant jaundice, you can have cholangitis. So if the patient has cholangitis, it does not necessarily mean that it is benign obstruction. The statement is other way around, correct, that if you take 100 patients with benign obstruction, more will have cholangitis as compared to 100 patients with malignant obstruction. But it is not that cholangitis rules out malignant obstruction. Now, this confusion is there in their textbooks and literature about periampullary cancers having waxing and waning jaundice. You have to remember that periampullary cancer is not one cancer. It is a group of cancers. Only the papillary type of periampullary cancer, where the tumor is at the papilla. Papilla is the nipple-like projection, which is into the medial side of the second part of duodenum, which you see when you do a side viewing endoscopy. If the tumor is sitting there, because it sloughs, temporarily relieves the obstruction to some extent, there may be melena, there may be some decrease in jaundice, but as the tumor grows, the jaundice increases again. But it is hardly ever that jaundice returns to normal, as it would in case of a CBD stone. And also this history is more frequently described in textbooks than actually seen in clinical practice. So if you have that history, fine. If you don't have that history, it doesn't mean that it cannot be a papillary type of a periampullary cancer. Next, go to your next slide. Yeah. So in first paragraph, you say history of fever. Next, you say no history of fever. These are contradictory statements. You should have said no history of low-grade fever, malaise, and body ache before the onset of jaundice. Once you say that, I know that you are talking of prodrome of viral hepatitis. Now, why did you ask about chest pain or hemoptysis in a patient with jaundice?
Sir, if it is a malignant cause, then if there are metastases in the lungs, then to rule that out,
I have said this again and again, and please remember that lung metastases usually do not cause hemoptysis. Lung metastases are usually silent. They are detected on imaging, chest X-ray, CT, or whatever. It is the pleural metastasis which causes pleural effusion. That can cause dull, diffuse, continuous pain, more commonly dyspnea on exertion. So that is more important rather than hemoptysis. And so if you are talking of metastatic history, you should talk of chest, which includes lung and pleural cavity. You should talk of brain, where you should say no history of recent onset severe persistent headache associated with nausea or vomiting. Convulsions and focal deficit are late features of brain metastasis. And similarly, bone metastasis, recent onset. Suppose the patient has back pain for 10 years. It doesn't indicate bone metastasis. Recent onset, persistent, severe localized bone pain, or spontaneous fractures on trivial trauma or without trauma. They indicate bony metastasis. Go to your summary. It doesn't mention the duration of jaundice. Duration is very, very important. The summary must include duration. So you should have said progressive jaundice for 2 months associated with dark colored urine and constant dull aching pain. Now stents. Plastic stent, the most common problem is block because their lumen is small. On the other hand, metal stent, the lumen is larger. But if you put an uncovered stent, then it is difficult to remove. The covered stents are easier to remove, but problem with covered stents is they are more prone to migration because they don't get stuck to the walls. And if you put a covered stent at the lower end of the common bile duct, which is bridging across the papilla into the duodenum, then it is likely to cause block of the pancreatic duct and can cause acute pancreatitis. So that is why you don't place covered stents at the lower end of the bile duct, which is one situation anywhere in GI where you would use a covered stent, which is the treatment of choice for a condition. Can you give an example? Tracheoesophageal fistula. If you have a tracheoesophageal fistula malignant, then an uncovered stent would not do the job, because then the food will still pass through the fistula. So covered stent is the treatment of choice there. Okay, carry on.
For my differential diagnosis, first I would like to put CA head of pancreas as my first differential. Then CA gallbladder, and lastly I would like to put distal cholangiocarcinoma as my third differential.
Why?
So CA head of pancreas first, because the pattern of jaundice goes more likely in the favor of malignant etiology. Secondly, the patient presents with pain in the upper central part of the abdomen, sir. Pain most likely, patients with distal cholangios are less likely to present with pain, sir. So, and carcinoma gallbladder, sir, because patient has pain in the right upper quadrant also, sir. That is why I would like to put these two as my first differential, sir, and then distal cholangio.
How can you say distal cholangiocarcinoma based on this history alone? Why not proximal cholangiocarcinoma?
Sir, patient presents with the pain in the right upper quadrant, sir, which could be because of a distended gallbladder or could be because of gallbladder mass. If it is a proximal cholangiocarcinoma, sir, then most likely the patient would not present with pain, first of all. And secondly, so the nature of the pain being more in the right hyper quadrant, sir, so it could be because of a distended gallbladder, which is unlikely seen in proximal cholangio, sir.
Yeah, so if you have jaundice, progressive jaundice, which you think is malignant, if the patient has pain, as you have rightly mentioned, pancreas followed by gallbladder, cholangiocarcinoma and periampullary carcinoma is more likely to be painless progressive jaundice. But you are right that a distal obstruction, because of whatever cause, if it is causing a hugely distended gallbladder, that can produce dull diffuse pain in the upper abdomen, right upper abdomen. But a hilar cholangiocarcinoma is very, very unlikely to be associated with pain. It is classically painless progressive jaundice. Is there any possibility of a benign etiology here? Yeah, that's what Sudeep wants to know. Can you put a differential diagnosis of choledocholithiasis?
Jaundice is intermittent mostly in choledocholithiasis, and here it is progressive.
So you should say that the classical clinical presentation of choledocholithiasis is colicky pain, biliary colic, although we know it is not a true colic, but biliary colicky pain associated with intermittent jaundice. And since that history is not there, since here is a history of progressive jaundice, which is associated with dull diffuse ache in the upper abdomen, and there is significant anorexia and weight loss, I would not like to consider a possibility of a choledocholithiasis. Okay, carry on.
So general examination, patient is conscious, cooperative and oriented to time patient person, moderately built and nourished. TCOG 1, BMI 27.2 kilograms per meter square. There is no pallor, but icterus is present. Scratch marks is present over abdominal lymph. There is no generalized or left supraclavicular lymphadenopathy, and there are no signs of liver failures. Patient is afebrile with pulse of 83 and blood pressure maintained at 134 by 82 millimeters of mercury with respiratory rate of 17 per minute. On abdominal examination, on inspection, there was mild distension present, but all quadrants are moving equally with respiration. Scar marks present over abdominal limbs. There are no visible dilated veins or visible peristalsis or scar marks are present. Umbilicus is centrally placed and inverted. Hernial orifice is normal, with the spine. On palpation, sir, palpable lump in the right hypochondrial region, which is globular shape, about 6 into 4 centimeter in dimension, around with smooth surface extending below the costal margin, firm in consistency, moving with respiration with side-to-side mobility present. Sir. There's no hepatosplenomegaly or other organomegaly seen. There's no fluid trail or shifting dullness, and liver span is 12 centimeters. On colorectal examination, there is no blood staining or melena and no pelvic deposits, sir.
Okay, go back to your general physical examination. Here you are saying scratch marks. Go to the next. Next, you are saying scar marks. What is the difference between the two?
So scar marks in previous surgical history, patient has any scar marks. Scratch would be
Not
because of
necessarily. If the patient has scratched very vigorously, there was some injury to the skin, that can become a scar. So in 2 months, it's more likely that they must be scratch marks rather than scar marks. So be careful in choosing your words. Go to the next. Yeah. So how can you elicit shifting dullness on palpation and liver span? You have combined palpation and percussion. If you are describing it under heads, then be careful. Some examiners, as I keep saying again and again, still insist that your history and examination should be as per MBBS protocol, which means that every part of the examination has to be separately mentioned. So if you are saying palpation, then you should have said percussion also. Otherwise, you keep on describing it as a story. As far as I am concerned, I am willing to accept a story, but some examiners insist on that. So be careful. So how would you like to summarize now? What extra information have you got on examination?
Sir, extra examination on the examination, sir, a lump which is palpable in the right hypochondrial region, which goes more likely in the favor of distended gallbladder, sir. So I'm anticipating that the block is distal to the insertion of cystic duct, sir. So most likely it could be CA head of pancreas, or it could be a distal cholangiocarcinoma, sir. Or
why not? Why not GBC?
So on the palpation, sir, it was more like it has a side-to-side mobility, sir, and it moved acquired the shape of a gallbladder, sir. A mass per se was not palpable, sir. Although it is difficult to differentiate between a tense cystic gallbladder and a mass, sir, but on examination, it was globular in shape, sir. It has a side-to-side mobility, so it appeared more like a distended gallbladder rather than a mass, sir.
Yeah, so you should be able to differentiate between a distended gallbladder, which you have described, versus a GB mass, which is in the GB area, but it doesn't take the shape or may not take the shape of gallbladder. It is more firm to hard. It will move with respiration, but it will not have side-to-side mobility. So distended, can it still be a GB?
Can it still be a GB mass?
GBC?
Sir, it could be, sir. Could be, sir, because it is difficult to clinically differentiate between a tense cystic gallbladder and a mass.
No.
Could be, sir, but
I'm just asking, is somewhere else, could it be a GB mass when you can't palpate that mass particularly? And with the same history of painful progressive jaundice.
Can you have a distended gallbladder in a patient with gallbladder cancer?
With same
yes, sir, a mass in the neck or head. Sir, there is a mass in the neck from the gallbladder, which is.
That's what Dr. Vinay Mahala is trying to hint you towards, that if you have a mass in the neck of the gallbladder, the mass is not palpable because it is small. It is the distended gallbladder which is palpable. So that this is again one of the exceptions against Courvoisier's law, because I'm sure Courvoisier never saw a patient with gallbladder cancer in his lifetime. So you can have a distended gallbladder and still it is not a lower end malignancy. It is a gallbladder cancer which is at the neck. So on one hand, it is causing obstruction of cystic duct and a distended gallbladder. On the other hand, it is causing infiltration of the common bile duct and jaundice, progressive jaundice. Okay.
On your history and your clinical examination, I am saying that this is a GB neck mass with jaundice. So could you differentiate? Could you justify yourself whether it is the other way around?
Sir, the pattern of jaundice would be same in both the cases, but here patients were also presenting with the pain in the upper central part of the abdomen also, sir. That is why I put my question.
GB neck mass will present as the right hypochondrial as well as the upper epigastrium pain. Because the pain is basically due to the stretching of the gallbladder, over distended gallbladder. So it will feel both in the epigastrium as well as in the right hypochondrium. So let's see what is your differential diagnosis, your confirmatory diagnosis on the basis of history and this examination. What you are concluding on diagnosis? This is your DD.
Yes, sir.
So if sir is asking you, what is your provisional diagnosis? What is it? What it is?
Sir, I would say my
Among
first
these three.
attention, carcinoma
No,
head of
you have
pancreas.
already given
Sir,
your
can
differential
I
diagnosis.
interrupt? Can I interrupt, sir?
Yes,
Yes,
please.
Rajan, please.
Yeah, see, if you have a CA gallbladder, even lymph nodes around the pancreas can cause obstruction to the biliary tree and cause jaundice. Even a porta-hepatic node can cause jaundice and lead to a distended gallbladder. So you shouldn't forget that.
So, what are the causes of jaundice in a patient with carcinoma of the gallbladder?
Sir, mass in the neck which is obstructing the bile duct, sir. That could be cause.
What else?
Sir, a mass infiltrating into the liver in advanced stage, infiltrating into the liver, sir. Gallbladder mass infiltrating into the liver, or
How will
along with
that
you.
cause jaundice? How will that cause jaundice? Can you have jaundice in a patient who has a mass in the fundus or body of the gallbladder?
Unlikely, sir, in quite very late stages, sir. Not in the initial stage.
How? How? So you can have a mass in the fundus and body and still have jaundice because there are nodes in the porta hepatis, in the hepatoduodenal ligament, in the peripancreatic region, which are causing biliary obstruction from outside. And this is a more favorable situation because this is one situation where even in a patient with jaundice, an extended cholecystectomy is the treatment. Whereas if you have GBC neck infiltrating the CBD, you will require to do a CBD excision. And if the portal pedicle is involved, right portal pedicle, you will have to do a right hepatectomy along with CBD excision. So third and rare, of course, much less common, is when you have jaundice because of stones, because many patients, 2/3 of patients with gallbladder cancer also have gallstones. So one of the stones may have slipped down. So that is a fortunate, favorable situation. And lastly, you can have a papillary tumor in the gallbladder, and a part of the tumor has broken off and embolized into the common bile duct. And again, these are uncommon, rare theoretical possibilities, which you should not mention in the clinical examination, but you should know them that if it is a choledochal cyst associated with gallbladder cancer. So these are, but the two commonest causes are GBC neck infiltrating the CBD and nodes causing compression. Now, Sudeep says that rather than mentioning liver failure, can we say signs related to decompensated chronic liver disease? Yeah, that's fine. That's okay. Okay, let's carry on. What will you do?
Sir, I would like to investigate the case. First, I would like to go for all the blood investigations, as in the complete blood count, the liver function tests, and in the radiological and in the radiological investigation after getting a chest X-ray done, I would like to go for an ultrasound abdomen.
Let's see.
So blood investigations, hemoglobin was 10.6 grams per decimeter. WBC counts for 13,600. Neutrophils
No
was
need to
84.
read. No need to read the reports. Give your interpretation. We can all read.
So
them.
WBC counts for marginally less. WBC counts for less.
Give your interpretation.
With differential counts, more likely, sir, in the favor of infective etiology.
So say that
blood counts.
there is evidence of sepsis and it confirms my clinical diagnosis of cholangitis. And there is no significant coagulation derangement. Okay, next.
Yes, derangements. Similar function tests are alphos was raised and the total bilirubin and direct bilirubin was raised. So it indicates obstructive jaundice with a cholestatic pathway. SGOT and SGPT were marginally raised. GGT was also raised, so it was more likely in the favor of an obstructive jaundice.
Yes. Carry on, carry on.
So ultrasound abdomen was done, in which the liver was normal with normal echo texture, but there was dilated IHPR in both the lobes. Right hepatic duct was 12 mm, with left hepatic duct to 11. And so all the intrahepatic biliary radicals and along with the distal CBD was dilated. Gallbladders were also distended, but there was no calculi.
Don't read the report. Give your interpretation.
Sir, dilated IHBR, dilated CBD with no apparent mass, and dilated MPD, sir, with no mass seen in the
So
gall.
your answer should be the ultrasound suggests a block at the lower end of the common bile duct, and the pancreatic duct is also dilated. There is no mass. So my diagnosis is, based on this ultrasound, what is your diagnosis?
Sir, it's a double duct sign, sir, with no mass in the pancreas. It could be a lesion at the ampullary level, sir.
So what is your diagnosis on ultrasound? If you were doing the ultrasound, what would you write as the diagnosis?
Lesion in the ampullary region, sir, because there's no mass.
Diagnosis is a periampullary carcinoma. There is a block at the lower end of CBD and PD is dilated. If only there is a block at the lower end of CBD and PD is not dilated, then your diagnosis becomes distal cholangiocarcinoma. If PD is also dilated, your diagnosis becomes a periampullary. Why I'm saying periampullary and not head of pancreas? Because no mass is seen, isn't it? So based on ultrasound, to a great extent, you can make the diagnosis. If only IHBRD is present, right and left duct are not even joining each other, the diagnosis is hilar cholangiocarcinoma. If IHBRD is present, confluence is patent, you see some part of the common hepatic duct, below that the CBD is not seen, the diagnosis is GBC neck. It could be a Mirizzi also, it could be a mid-CBD cholangiocarcinoma also. If the CBD is dilated till lower end, but PD is not dilated, then the diagnosis is distal cholangiocarcinoma, which is also one of the periampullary carcinomas. If both CBD and PD are dilated and no mass is seen and the two dilated ducts are approximating each other, the diagnosis is periampullary carcinoma. If both CBD and PD are dilated, but they are far from each other, and there is a mass which is separating them, then the diagnosis is CA head. So a good ultrasound can virtually make the diagnosis. Okay. Now, who is it? Milton Swankar wants to know, is it still relevant that solitary gallstone is more likely associated with CAGB than multiple stones? See, there is very little evidence, very soft evidence. And the evidence available so far is that there are some reports which say that a large stone, large means more than 3 centimeters, the risk of gall, it is not association, it is the risk. Risk is more than with a small stone. But there are other reports which say that this is not correct. There are few reports which say that if the gallbladder is filled with stones, packed with stones, that means that the stone gallbladder volume ratio is almost near 1, then the risk is more. So these are all very soft evidences, and there is evidence for as well as against. Now, Sudeep wants to know, in the exam, can we say directly to do cross-sectional imaging instead of ultrasound? No, because in hepatopancreaticobiliary malignancies, if ultrasound shows metastasis in the liver, then in most situations, at least for your exam, you will not go ahead with the resection. So then CT probably or further imaging probably would not be indicated unless you want to do it as a baseline for follow-up or as a trial or see what the response is. But as far as surgical management is concerned, in most cases, it will put a full stop. As opposed to colorectal malignancies or GI malignancies, where even in presence of metastasis, you will probably go ahead, or in most cases, you will go ahead with resection. So there, it may be plus minus, but in HPB malignancies, I think you should mention ultrasound and chest X-ray as the first investigation. Okay, what next?
So now I would like to get a triple phase IV contrast CT and abdomen, contrast scan of the abdomen.
Sorry, say again.
So triple phased contrast CT abdomen. It will be my next investigation.
What is triple phase?
Sir, triple phase contrast CT after giving IV contrast, sir. We look for an early arterial phase, delayed arterial phase, and a portal venous phase, sir.
So is there a difference between triple phase, say, for a liver lesion and a pancreas lesion?
Yes, sir. In pancreatic protocol CT, sir, in particularly pancreatic protocol CT, sir, the time of acquisition of the image along with the volume of the contrast and the flow rate of the contrast is important. So high volume of the contrast at high flow rate is given, and the image acquisition, the timing, like an early arterial phase after a scout image, early arterial phase is taken at 15 seconds, and a delayed arterial phase, which is the pancreatic parenchymal phase, is taken at around 35 to 45 seconds, followed by a portal venous phase, sir, at 60 to 70 seconds, sir. And if we want to go investigate further for cholangiocarcinoma, sir, then a delayed phase also becomes important, sir. After 3 to 5 minute delayed phase is important.
So there is a difference between contrast enhanced CT, a triple phase CT, and even in the triple phase CT, there is a difference between whether you are trying to look at the liver or whether you are trying to look at the pancreas. So the differences or the specifics are what kind of oral contrast you give in pancreatic protocol CT. Most radiologists would either not give any oral contrast or they will just give a negative oral contrast, not a positive oral contrast. The volume of contrast, the rate of injection of contrast, the acquisition timing, all these are very specific details. So in this case, which specific CT you would like to have?
Triple phase contrast CT, not the pancreatic parenchymal phase, sir, because I could not see a lesion of the pancreas.
Pathology at the lower end, although there is no pancreatic mass, but we know that ultrasound may not pick up a mass, but there may be a mass on CT scan. So if there is a mass in the head of the pancreas, you want a pancreatic protocol CT, isn't it? So you should say that I would like to have a pancreatic protocol triple phase contrast enhanced CT scan. Why the early? You said that the pancreas parenchyma is seen in the delayed arterial phase. So why the early arterial phase?
Sir, early arterial phase would be if there are any neuroendocrine tumors, particularly, they enhance in the early arterial phase. So,
Yes.
Also the liver
Okay.
mets.
Let's see the CT. We have the film.
Sir, I have a video recorded, sir. Of the,
Can we play it?
Should I play it again, sir?
Not yet. We are just seeing your slide. Stop sharing and then share again.
Is it
Yes.
visible now?
Yes. Keep describing what you see, whatever you see.
Yes, sir. Sir, I could see dilated intrahepatic biliary radicals here, sir. It's being a portal phase, axial cut sections. I could see dilated intrahepatic biliary radicals in the liver with no metastatic lesions, sir. Liver parenchymal ecodexture appears normal, sir. There is the dilated bile. There is a distended gallbladder I could see, sir, but there are no stones seen. And here I could see a double duct, sir, dilated CBD as well as the pancreatic duct.
How do you make out the difference between a smaller choledochal cyst and CBD dilatation in stone or in carcinoma of the pancreas?
Sir, depending on the type of the choledochal cyst or fusiform, massively dilated bile duct, sir.
What about a fusiform one?
Sir, dilated
CBD
IHB are
Type
usually
1A
in type
and
1.
type 1B, right? Type S.
Sir, intrahepatic biliary radicals are usually intrahepatic ducts is not dilated in type 1 choledochal cyst, sir. Only the extrahepatic bile duct is dilated.
Comparatively, the intrahepatic ducts will be less dilated.
Yes.
So the key word is disproportionate dilatation of the extrahepatic biliary system as compared to intrahepatic ducts. Here you see dilated extrahepatic as well as intrahepatic ducts, and they are symmetrically or proportionately dilated. So this is more likely to be mechanical obstruction. In choledochal cyst, it is a disproportionate dilatation of the extrahepatic biliary system. Suppose you said that I don't see any liver metastasis. Suppose an SOL was seen in the liver. What would you think?
Sir,
And other is on CT scan, you should not comment about gallstones. Ultrasound has already been done. Ultrasound is much better than CT scan to pick up gallstones. And that has shown that there are no stones. So there's no need to say that I don't see gallstones on CT because CT is not the best investigation for gallstones. So you see a SOL in the liver. What do you think?
sir, if it appears like a metastatic lesion of CT, sir, then I would like to go for a biopsy done, sir, in that case, and also will plan for a pre-operative drainage, sir.
So that's the only possibility if you see an SOL in the liver.
Sir, usually in USG, sir, the characteristic features of benign and malignant lesion would differ. Like a benign, malignant would appear hypoechoic, while
So no other lesion can look like a metastasis.
so abscess can look like a metastasis. Abscess can mimic as a metastasis.
How would a cholangiolytic abscess look like?
Sir,
This patient has cholangitis.
Sir, a hypoechoic rim would be there, sir, in cases of abscess, sir, which will not be there in metastatic lesions.
They would both look the same. There are
Sir,
subtle
after a drainage, sir, after drainage, the abscess should resolve, sir, but the metastatic lesion would persist, sir.
Yeah, so based on a single imaging, sometimes it is not possible to say whether it is a metastasis or cholangiolytic abscess, especially since patient already has history of cholangitis. So your answer should be that on ultrasound and CT, they may look the same. There are several ways by which you can differentiate. There are some subtle radiological features. Check with your radiology colleagues, but probably a peripheral enhancement around the lesion is more suggestive of an abscess. Irregular, shaggy margins would probably suggest an abscess. And then either you give parenteral antibiotics or drain the biliary system. And if the lesion resolves after a period of time on imaging, then it is more likely to be cholangiolytic abscess. So that is how you differentiate. And of course, final proof has to come from ultrasound or CT guided FNAC of the lesion. And as a student has pointed out, that you have to keep in mind other common lesions like simple cyst hemangioma, but they have characteristic features. Simple cyst will be anechoic. Ultrasound, well-defined, rounded, anechoic lesion with no peripheral enhancement. Hemangioma will be classically hyperechoic, and it will have the typical features on triple phase CT scan. So most common problem is to differentiate between a liver metastasis and a cholangiolytic abscess. What else you want to tell us on the CT scan?
CBD appears grossly dilated, sir, here. And also the pancreatic duct appeared grossly dilated, but apparently I could not see any lesions, sir, in this. Any lesion or any irregularity? No mass, sir.
In the head of the pancreas. And since there is no mass, vessels are not important, but still you should show us the superior mesenteric artery, superior mesenteric vein, portal vein. You should show. And Sudeep again has asked involvement of these vessels. Now, involvement of these vessels is important when you are talking of CA head pancreas, when there is a mass in the head of the pancreas in the uncinate process. But in periampullary carcinoma, because there is no mass in the head of the pancreas seen on imaging, you are not bothered about these vessels. These vessels are invariably not involved. The only reason why you cannot resect a periampullary carcinoma is a distant metastasis rather than local unresectability. But show us the vessels.
Could see the portal veins. The main branch of the portal veins, sir.
Okay, what else would you like to comment on the CT scan?
Sir, no apparent lesion in the pancreas, sir. And no ascites, sir. USG also will give an idea of the ascites.
What about lymphadenopathy?
Lymph nodes. So you should have a fixed protocol to describe CT scan in any patient with malignancy. You could follow any, but you should not miss anything. And very importantly, you have to talk of liver metastasis. You have to talk of the lesion. You have to talk of the important adjacent structures, especially the vessels. And if it is a large mass, then adjacent organs. And then ascites, lymph nodes, any peritoneal omental deposits, any pelvic deposits, which can be seen on a CT scan, especially with a thin slice CT scan. So even small lesions can be seen. So all these things, you have to make a mention that whether they are there or they are not there to complete the description of the CT scan. Let's go back to the report. Yeah, Sudeep says that features related to portal hypertension, but since this is only a 2 months history of jaundice, you are not thinking of secondary biliary cirrhosis. You can have a malignancy in the biliary tree or in the pancreas causing portal vein thrombosis and then portal hypertension, but not secondary biliary cirrhosis. 2 months is too short a history to think of secondary biliary cirrhosis. Yes.
So CCT of suggestive of abrupt cutoff of distal CVD near ampulla, sir, which resulted proximal dilatation. So there was no definitive mass seen in CT also, sir. No signs of metastasis were present, and all the intrahepatic biliary radicals along with gallbladder, cystic duct, and NPD was dilated throughout the regions.
So what is the diagnosis based on the CT findings?
Sir, a lesion in the ampullary region appeared more than this.
Yeah, again, the diagnosis is periampullary carcinoma.
What is the
Now,
importance of IHBD?
Rajan, we could not hear you properly.
Yeah, what is the importance of IHBD in patients with GB and pancreatic malignancy? Can there be some situations where the intrahepatic biliary dilatation is not there?
Solution.
Sir, long-standing complete obstruction would lead to a reflux dilatation in the intrahepatic biliary radicals in both the ampullary regions also, and in the gallbladder neck, which is compressing on the cystic duct also, sir.
Sure. Okay.
Okay, what will you do now?
Sir, I would like to go for an ERCP in this case, sir, along with the drainage and also the biopsy, sir.
Why
Or
do you
I
want to
could
do
also,
ERCP?
sir, I would like to see if there is a lesion, and if the lesion is present, I would like to go for a biopsy also. If in case the lesion is not seen on
That is called ERCP.
EOS, or sir, I would. The lesion is not seen, then an endoscopic ultrasound, sir, because I could not see a lesion, sir. So
The endoscopic ultrasound is a different procedure altogether. What you said that you want to see whether there is a lesion at the papilla and take a biopsy, what is that procedure called? So again, students, you must be clear that there is a difference between side viewing endoscopy and ERCP. Side viewing endoscope is used for doing ERCP, but what is required in this case is only a side viewing endoscopy. That means you go there to the second part of duodenum, look at the papilla, see if there is a growth and take a biopsy. You don't want to do a cholangiogram. Again, what Dr. Desai was saying earlier, there is a biliary obstruction. If you do a cholangiogram, which means you put a cannula or you inject contrast, you are bound to introduce infection. And therefore, it is not indicated. ERCP for diagnosis today is virtually out because you can get the same information, diagnostic information from an MRCP. ERCP is done only as a part of a therapeutic intervention. So the first aim here is to do a side viewing endoscopy and a biopsy from a lesion. Which lesions can be seen on side viewing endoscopy and which lesions will not be seen on side viewing endoscopy?
So papillary lesions, any lesion in the papilla could be seen on the side viewing endoscopy. But if it's a peripapillary region, sir, then side viewing endoscopy would not be that helpful. Sir. And ampulla also, side viewing endoscopy would be helpful.
What of
So
APPDJ and its importance in GI malignancy?
Sorry, sir?
APPDJ, abnormal
abnormal pancreaticobiliary
duodenal junction.
Yes, sir. It increases the risk of malignancy, sir. In case in patient, it's a cause a predisposing factor for
Suppose
choledochosis.
the system is not dilated, what malignancy it causes, and if the system is dilated almost like a choledochal cyst, in that case, what does it cause? The answer is, if it's undilated, you can get gallbladder malignancy. If the system is dilated, then it's more likely to cause peripheral cholangiocarcinoma.
So when you do a side viewing endoscopy, the lesions which you are likely to see are obviously a duodenal carcinoma, a peripapillary duodenal carcinoma, which is also one of the periampullary cancers because it causes obstruction to the papilla or the lower end of CBD and presents with jaundice. A true papillary carcinoma, tumor which is sitting on the papilla. On the other hand, a true ampullary carcinoma. Ampulla is the common channel formed by the lower end of CBD and the terminal part of pancreatic duct. That will not be seen. A small pancreatic head cancer will not be seen. A large pancreatic head cancer which has infiltrated the duodenum or an uncinate tumor which has infiltrated the duodenum will be seen. So if you see a lesion, you can do a biopsy from there. Now, if you don't see a lesion, you have options. One is that you put a brush into the ampulla and take a brush cytology. Or you put a cannula, take the juice, bile or pancreatic juice, do a fluid cytology. Or as you were mentioning earlier, you do an endoscopic ultrasound, you see the mass, a small mass which was not seen on CT will now be seen, and you take an EUS guided FNST from the lesion. So these are ways to get a tissue diagnosis in a periampullary carcinoma or a head pancreas. Now, there is a comment by Milton that in NCCN guidelines, the recommendations in HPV cancer is to use either CECT or CEMRI for diagnosis and planning, but most centers in India end up doing both CT and MRI. Some centers also operate based on normal chest X-ray, while thoracic CT is mandatory to rule out lung metastasis. Okay. So as far as lung metastases are concerned, yes, you should mention a chest X-ray first. And if the chest X-ray is normal, you should say that when I'm doing a CT of the abdomen, I would like to include CT of the chest. I think more and more centers are moving toward that because we know that chest CT is more likely to pick up a lung metastasis as compared to a chest X-ray. As far as CT, MRI or both are concerned, by and large, in general, lower end block, CT alone is enough because you are not interested in too many details of the biliary anatomy because you are going to do a PD. Whereas if it is a proximal block, hilar cholangiocarcinoma, gallbladder cancer with obstructive jaundice, most centers probably would do both CT and MRI with MRCP because you want to know the vessels, you want to know the local extent, and you want to know the biliary anatomy. That is what is going to decide your extent of resection. Okay. So I think we are at 10. We need to close. So students, please send me a mail, vkkapoor.india@gmail.com. Just write pancreas in the subject of mail. So I'll send you the chapter on lower end block. And you are logged in with Dr. Dhruv's email ID, is it? But
I send you my email ID, sir. I have taken someone else's laptop, so I think I'll send you my ID.
so no, I wanted to ask you that would you be willing to prepare the next part of this, that what will be the treatment? Because
Yes,
in
sir.
continuation next week we can do that. We haven't covered the surgical part, the preparation and other things. So if you volunteer, then inform Dr. Anand that you will complete this in the next Saturday session, and
Yes,
we
sir.
will discuss the treatment of this patient. Okay?
Yes. Yes.
Yeah, good.
Thank you, sir.
Any other comment, Rajen? Any other faculty member?
No, nothing, sir.
Any student wants to ask anything? Okay, then we will close the session. Thank you. Thank you very much.
Yes, sir. Thank you, sir.
And you can ask for one extra chapter for your presentation today. You can write 2 chapters. Send me 2 separate mails, one for this and one for any other chapter.
Yes.
Okay.
Thank you, sir.